All right, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after the Journal Club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability for any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. For all athletic trainers intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You'll have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. And then also for those who had previously attended the diving and altitude medicine one, someone had mentioned, reached out to us to say that the date was incorrect. We did get the date updated and that has been re-uploaded to our website so you could re-download your statement of credit if you had attended that one. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. So today, Dr. Russ Hostetler is currently a senior medical officer with the Marine Corps Marathon Organization and is a volunteer physician for the Medical Reserve. He received his medical degree from the Medical College of Ohio at Toledo. He has had multiple roles in his career, include a family practitioner, assistant professor at Mercer University and at the University of South Florida, and medical director for multiple projects and companies. He is speaking today on endurance medicine and the adaptive athlete. And I'll have you take it away.
Thank you, Dr. Henney. It's a pleasure to be here. I hope you can see the slide. The first slide is a picture of the last crew, the last team with which I worked for the Marine Corps Marathon this past October. This boy right here, can you see my marker? Is me. And the other yellow-capped guy, I thought was a physician, turned out to be just a PA, but he was educable. So we had a good day, even though he learned a lot, I think. This big boy here is my partner in crime. He was the officer in charge, retired Coast Guard commander, Andy Neiman. He is also an EMT, and he and I work very well together. These boys are from the local EMT and fire department, and this big boy here is our connector with the ham radio, which we need in order to ascertain if runners or people who come to our tent are actually participants in the race. The blue-capped folks are corpsmen, which means that they are medically trained Navy personnel. Most of them are trained in hospital medicine, but they come out and help us. They have skills that are similar to an EMT, and of course they've advanced through the ranks. You also notice that this guy is also in the Navy as he's wearing his Type 2 uniform. His red cap shows that he, though, is an RN, and this volunteer is an RN from a local hospital. These two ladies are physical therapists, orange caps, and this lady with the pink cap is an administrator. This lady that I did not have the skill to reduce the photograph to fit has a white cap on, and she is our supply officer. And there are two other people that are supply and and regular officers that are not in this picture. These two gals were very busy, and the reason why they were very busy is because for this past year, I did not have any ATs on my team. In the previous year, I had a person who was teaching as PhD in athletic training and brought with him 3 students, and they were busy. So can you imagine what we were dealing with when we did not have the helpful benefit of ATs at our station? This is aid station Delta. It's about 3/4 or 8/10 of a mile from the finish line. And even though it is that far from the finish line, it is a prime spot for people to experience exercise-associated collapse. We'll get into that in a little bit. And I'm going to try to advance this now. If I can figure it out. There we go. I have no relevant financial relationships. I'm not going to discuss any products by name. I must tell you that I have permission to distribute these guidelines to you individually, and I hope that you have them available in front of you so you can make notes on them if you'd like. Further distribution requires additional authorization. So if you want to use these in an event and share them with other people, you need to get in touch with the Consortium for Health and Military Performance at the Uniformed Services University of Health Sciences there in Washington. And those are the folks then who can give you further permission for further distribution. The objectives that I think we can get to today is to review these algorithms which show us the conditions with which participants are likely to come to an aid station for an endurance event. Endurance events can be marathons, half marathons, trail races, the obstacle course challenge at Paris Island or Quantico, and also the 100-minute run, which is really a thrill, where you get teams running for 100 minutes and they go as far as they can, and many of them drop. I want to emphasize that it takes a team of training providers to meet the needs of all the folks coming to our aid stations. It becomes a mass casualty event when you have 30,000 runners and a whole bunch of personnel trying to help them. Stuff shows up, and it shows up all around the course, and even a mile beyond the course. We'll try and point out as we go through the algorithms where ATs are helpful in the aid station teams, and we're also want to point out, make you aware of, be able to respond to the special needs of adaptive athletes, including special athletes, for example, people with Down syndrome who do participate in these endurance events. I previously stated this is the Consortium for Health and Military Performance. It's part of the Uniformed Services University Health Sciences. The developers of these algorithms are not only this group, but also those of us in the Marine Corps Endurance Events section in Marine Corps Marathon Organization, and the International Institute for Race Medicine, of which Chris Troyanos is our primary contact. I'll just point out again that these are the people with whom I play. Connor is a colonel, a West Point graduate, and his current assignment and has been his active duty station for the last decade has been at USUHS. And he is very knowledgeable and a very helpful person, very good. Commander Ridings is my boss. She's top doc for the marathon and the other large running events, and also many of the other endurance events, such as the obstacle course challenge. She is a family physician, trained also in sports medicine. Shelley Weinstein is a retired captain in the Navy. She is a doctor of education, and she has her own business teaching ALS, PCLS, and all those things. But she is our coordinator for the Marine Corps Marathon Organization. And I worked with her for over a decade. Mark Manson is now a commander. He was a lieutenant commander, presidency at the German military base, and his entire career has been with the Marine Corps, similar to me. All of my work as a volunteer for the Navy has been with the Marine Corps. Matt Sately is a huge guy. He is 6'7", all of 300 pounds, and he's a sports medicine doctor who is very active at running and biking. He is also the team physician for the Baltimore Orioles. Chad Hozoppel is a lieutenant colonel in the Army. Enough said about that. Need to press on. Chris Trianos, I mentioned, is a medical director for the Boston Marathon. He was the one that oversaw the events following the bombing and the tune-up that they did of their facilities and algorithms following that. He is a terrific person. He has no degrees other than being a certified athletic trainer, but he is top-notch in his field. I'll mention one other person, and that is my friend Bruce Adams. Bruce retired a couple of years ago as a captain from the Navy. He was our former medical director and top doc for the Marine Corps Marathon, and he is an expert in rhabdomyolysis, from whom I learned a lot. This is a table of the algorithms. There are 18 algorithms. You can see it embraces the top 10 endurance event conditions, plus additional algorithms to address special circumstances, such as infection control necessitated by the pandemic, and the recognition of sickle cell trait that can express itself under these circumstances. We also added the adaptive athlete algorithms, and like I said, Commander Madsen is the one who rose to commander on the strength of that input. The latest additions are the meds and supply list, and I will note at this point that my suggestion of the past decade to include athletic tape and wet drill has yet to make good cut. They do have wet drill and athletic tape at the Alpha aid station, but it hasn't made its way out to those of us who still need it a mile from the end. I'll point here to the fact that tent discharge, we're talking about the aid station tent, which you saw in the photograph earlier. This is the triage algorithm, and I'll emphasize that it is triage. We want to go through this to see where we can point people to exit to the appropriate treatment algorithms. You notice that we want to know whether or not the person is responsive or not. This is the situation that we get sometimes. People walk in, sometimes they're carried in by a gator, sometimes they're carried in like a sack of potatoes over the shoulder of a Marine. In any event, when we get that situation, we need to know what's going on from the vital signs, and if we don't find a pulse right away, we have to go to the emergency cardiac care algorithm, which we'll review next. If we do not have a responsiveness problem, that is a double negative, not unresponsive, we have to think about sickle cell trait and signs of exercise collapse associated with sickle trait. There is an algorithm for that, so we'll go over that later. Altered mental status ends up being a major but non-specific finding. If you have altered mental status, there's so many things that could be going on. But depending on the weather, depending on what's going on, we might need to think about whether or not the person is hyperthermic or hypothermic, and we've had both at the Marine Corps Marathon, which takes place, by the way, at the end of October. The point I want to make here is that we only deal with rectal temperatures. The physiologic changes of circulation that accompany endurance events and the extreme exertion change the circulation such that you cannot get a useful number from either sublingual or the ear canal or the forehead or axillary areas just in the rectum. And we shove the thermistor of a electronic device up the hind end of our athletes under all circumstances that required except for one, and that is if they refuse it. And if they refuse it, then we go by golly and do the best we can. Note that this algorithm prompts the consideration of adaptive athlete issues, and especially those who have altered mental status and normal body temperature, but adaptive athletes can show up anywhere with anything. And so we need to continue to have an open differential diagnosis when we're looking at patients and go to the appropriate algorithm or transport. This algorithm doesn't cover anything except triage. This is the first treatment algorithm, and it is the first perhaps because it is the most important. When I see this algorithm, the first person I think of is Damar Hamlin. And any one of you could be the AT on the sidelines at the football game where such an event takes place. Any one of you could be the person who witnesses such a collapse. Any one of you could be the one who is the first responder, and any one of you can save a life. One thing that occurred to me when Damar Hamlin went down is that every second counts. When it comes to keeping blood flowing to the heart and brain, every second counts. If you can't find a pulse immediately, start CPR. If the patient is not obtunded enough to require CPR, he or she will let you know straight away. Pinch compressions of the sternum for them to say, wait a minute, I'm not dead bad. And there are, again, blood pressure, blood flow changes that can obscure even a carotid pulse when you're in these circumstances. One of the things that we advocate is that if someone comes in with a cardiac event and you can identify it straight away, get EMS started right away and get the AED in place, because that's the only electrical information that we're going to have. And it's important, again, every second counts. If you follow the AED prompts, you might shock the manure out of somebody, but if it gets a pulse back, hooray, they still go to hospital. Under these circumstances, everybody goes to hospital. I'll point out down here that this says CAB, circulation, airway, and breathing, but here it's misrepresented, circulation, breathing, and airway. You got to make sure that the airway is open before you can start blowing air into somebody's lungs. So it's CAB, not CBA or ABC. This is the exercise-associated collapse algorithm, and it's second because it is the most common. This is what exercise-associated collapse looks like. And this. You'll notice, and I'll see if I can find my way to go back. Yeah, good. You'll notice that this woman is not sweaty wet, but I'm in a t-shirt. This is me, by the way. I'm in a t-shirt because it is warm out. She's dry, and look at how sunken her eyes look. This woman is dehydrated, and that is part of her collapse. Notice the mouth is open. Same thing here. The changes that take place with exercise-associated collapse are related to the fact that even with continued movement, when you stop running or when you have exhausted every ounce of energy to run, blood will pool in your extremities. It will leave your noodle. It will leave you relaxed in the face, but it will cause you to collapse. Sometimes symptomatic people will show up on their feet near collapse. And if that's the case, we do the same thing. That is, we get them in Trendelenburg position, and we set up our ACE station to make that the sine qua non. That is what we do first, is put somebody in Trendelenburg. I'll make a note here that if you have an adaptive athlete who does not have any legs to elevate, it's important to have their butt higher than their head. That is what Trendelenburg came up with. Friedrich Trendelenburg was a surgeon in the late 19th and early 20th century. And I had been trained in the military that he was a surgeon, a military surgeon, that had found that Trendelenburg positioning could preserve brain and heart in people who had severe combat-related wounds. But I couldn't find that in Wikipedia. In fact, they just disputed that altogether. This boy was a surgeon who, in operating on people with abdominal problems, put them in Trendelenburg so gravity would get their guts to float up toward their diaphragm so he could work on their lower abdominal structures without having the guts fall out. One of the things that you're urged to do if they have altered mental status and it is improving, if it's not improving, we need to check and see whether or not we need to go further or send them to hospital. If they have altered mental status that is improving, we check their hydration status. Some of the things that you can look for are urine color, if you can get some urine. A good test at the start of any race is to hydrate to the extent that your kidneys give you clear urine. I don't know if you've heard that before, but we've proved it. That gives you a good place to start. And then if you respond to the thirst drive throughout the course of your event, you should be in good shape from a hydration standpoint. However, a lot of people, and years where history comes into play, a lot of people will say, well, what did you drink on the course of the race? And they say, I stopped at every water station and I drank all of the Gatorade that I could. Well, Gatorade is still hypotonic. So if you're drinking Gatorade, you're still likely to be hyponatremic because there's not enough salt in Gatorade to replace it. And we'll talk more about that in the hyponatremia guidelines. The other thing is look for mucous membranes. In the pictures of those women, one of the things that we noticed were the sunken eyes, but also their mouths are dry. Skin turgor is another thing you can check. It's fairly unreliable, but if you can tent the skin and it stays tented, then they're probably dry. Hyperthermia, what I just talked about. We need rectal temperature. Excuse me. And if it's greater than 104, what you're going to hear me holler as the SMO in an aid station is start active cooling. That means that we're going to bring that participant, that athlete, to one of two situations. It's either going to be a heat deck, which is the term we use to describe a kind of a kiddie waiting pool sort of device long enough that we can put a patient over it on a cot. We put water in it and we put ice in the water and we scoop that ice water over the patient continuously while we have the thermistor in their rectum so that we can monitor their temperature change. We want to quickly cool them if we can. And when we get them down to 102 or less, we stop active cooling because we don't want to overshoot. And if we overshoot, then we have to go to the hypothermia algorithm and add some heat back. But we only go there if they have a persistent altered mental status or central nervous system dysfunction. If they come in and they're hot, but they're not 104, then we initiate simple cooling techniques. And these are outlined for you below. moving to shade, a cool environment, using ice packs. You can put them in the axillary areas or in the groin creases behind the neck, and forearm immersion, or taking an ice pack and just rubbing their forearm in order to get them cool. Historically, in the past, our aid station had a bank across the street, and during the hot months, we could move our hot patients to the bank lobby. We literally commandeered the bank lobby in order to take advantage of the air conditioning. They came in too cold, we commandeer the bank lobby in order to heat up our patients because it would be a heated environment. If we don't have the heat deck, we have what we call the taco method, and that is literally a body bag, a black plastic zip-up body bag. You put the patient in the body bag, you put gallons of water and ice in the body bag, and you have personnel on either side to lift and lower the sides rhythmically so that you slosh the patient back and forth in the ice water, maintaining that rectal thermistor in their rectum and the wire from that coming out next to their neck so that you can monitor their temperature. Again, we stop this active cooling once they get down to 102. If they have the persistent symptoms of, if they do not come down quickly to 102, we have to consider other causes for hyperthermia. We do not automatically transport heat patients. Sometimes, if they are able to get cooled off and their initial temp was less than 106, and they get better and they're improved, we can let them go if they have supervision. Make sure somebody's going to be going with them to monitor for recrudescence of the hyperthermia. If this patient starts between 104 and 106, responds nicely, remains stable, we give them a good 30 minutes, and with prolonged observation, they could be discharged. For the most part, all heats that go to the deck are going to end up going to hospital. Why? Because of the sequelae. And if you've got somebody that's a 108 when they come in, no matter what their response is, they're going to hospital. They have to be observed and further treated, and the labs and all that taken. One of the things to watch out for hyperthermic people is this emotional instability thing. They can be emotional, or they can be mentally disorientated. But this instability thing is that they can suddenly become combative. If you haven't dealt with the heat before, beware. I had a corpsman that was trying to start an IV in the left-hand cubital fossa, and before he knew it, he got decked with the left cross to his jaw and knocked out. So wary of the fact that they can become combative. Got to talk to them, calm them down if you can, restrain them if you need to, and deal with the active cooling business. One of the things that has to be in differential diagnosis, and I won't spend too much time with this, I hope, is malignant hyperthermia. And why that needs to stay in the diagnosis is because it's rare, but it can happen. It is an inherited problem. The rhianodine receptors in skeletal muscle is abnormal, and this leads to an increased calcium ion concentration in the muscles. That leads to increased metabolism. So this hypermetabolic state leads to increased carbon dioxide, which adds respiratory acidosis to the metabolic acidosis that's frequently there from an exertion event. And it increases sympathetic tone. And part of that whole process is they are hot. And we have to do the active cooling thing, but we have to be aware of the fact that if they're in the active cooling state, but they have these symptoms of increased sympathetic tone, for example, their heart's racing, or their breathing is fast, and they are hyperkalemic because of the of the acid shift, that is, they have a high potassium level, and if they have muscle rigidity, and that will come up again soon. If they have muscle rigidity as a part of this picture, it could be malignant hypertension. This needs to be diagnosed with a muscle biopsy. These people go to hospital. The other thing it could be is neuroleptic malignant syndrome. Well, that has to do with antipsychotic medicines, things like clonazepam, quetiapine, and risperidone. And you don't think that psychotic people are going to be out there running races, but they do. Number one, a good therapy for anybody with mental emotional disturbances is exercise. In any event, not only do they show up taking these medicines, but they may have traveled across the country to get to your race and have been given a prescription for quetiapine because it is strongly sedative. And the well-meaning physician who misappropriately prescribes this medicine to them is setting them up for a problem, because even 10 days away from one dose of a neuroleptic could be enough to change the metabolism to allow for the hypermetabolic state that goes along with neuroleptic malignant syndrome. And again, they do show up. Let's see. Hypothermia, if we overcool them or if they come in cold anyway, and if it's a cold environment, if they're cold, we try to warm them up. Initial therapy is to keep them supplied, but to remove wet clothing, we want to stop evaporative cooling, and we want to block heat escape. So we want to make sure that they have warm blankets on them and a mylar blanket with the shiny side toward them. You don't want the mylar blanket to absorb the heat, you want it to reflect it. I don't know that that's a big issue, but they pound that at us anyway. So we initiate this passive warming thing, and of course we've got a rectal temperature that's below 95, and if that temperature is steady or comes up, we continue the passive warning. We encourage them to shiver. We provide warm beverages if they can tolerate PO, in order to add warmth via the GI tract. And then we observe them for a long period of time to make sure they don't recrudesce. If they're cool, adios. If they're not, or if they continue to be too cold, we have to initiate active rewarming. And those kinds of things have to do with making sure that there is additional warmth applied, or to move to a warm environment, as I mentioned previously, or warm oral fluids if they tolerate PO, or warmed IV fluids. And we have had Marine Corps marathons at the end of October where it was freezing outside, and we did have to use warmed IV fluids before we could transport the patient to hospital. To warm IV fluids, we put an IV bag, a 500 milliliter bag, into a microwave. We have a generator that can power the microwave, and we give it 20 to 30 seconds, and then we put two bags together, and we put the thermistor between them, like putting the thermistor between two butt cheeks. And then we measure the temperature. And if it's 104, which we previously noted 40 degrees Celsius is 104 degrees Fahrenheit. If it's 104 to 106, then we can put it in. If it's hotter than that, we don't want to do it because we don't want to damage the blood vessels. So that's one thing that can be done, and you'll see that, I think, if you work in sports in the north. I remember as a soccer player, I was a goalie, punted the ball out of the goal, and it disappeared into the snow. The white ball disappeared into the snow. It was wonderful. Exercise-associated muscle cramps. This is where you guys shine. You know, how does the body know how much muscle tone is needed? I don't know if you know this, but I'll review it briefly. There are sensors in the muscle spindles that detect stretch, either change in length and the rate of change, and they send this information to the spinal cord, to the rubrospinal tract. And when it receives this information, a reflex contraction is triggered to maintain tone. So if you're falling forward, that stretch on the gastroc from having your heel down gets sent to your spinal cord, and a response comes back to tell your gastroc to contract to pull you back upright. It's to maintain postural tone. If that goes awry, and it does go awry, as I'm sure you are aware of, specifically or particularly with endurance events, or when you go into the second overtime in a football game and those kinds of things, even towards the end of the game, if you have someone who's been particularly aggressive in their play, they can have cramps. And we all know that the primary treatment is to maintain mobility if we can, but to get them down and passively stretch the cramped muscle, usually the gastrocs. That means you move the toes toward the nose. And while we're doing that, we can ask them about their hydration status to make sure that if they do need some oral salt solutions, we can get that in. I will tell you, though, that nobody knows what causes cramps, and nobody knows how to treat it specifically. If you find out what causes it and how to treat it specifically, let me know, and we will both share the Nobel Prize for Medicine that year. But they do happen, and we know we have to stretch them out. If you have both anterior and posterior compartments, that can be a real challenge, because as soon as you put the toes to the nose, the anterior chamber goes into spasm, and as soon as you pull the toes down, the posterior segment goes into spasm. And it's a hell if you do, hell if you don't situation. Under those circumstances, you can try adding an ice pack massage the affected muscles to see if you can interrupt the signals that are going from those muscles, the aberrant signals that are going effectively from those muscles up to the spinal cord at the back. So if they're approved, okay, bueno, adios. We'll send them home. We're going to get them up and walk around first and make sure that they're stable. Under this circumstance, I'll mention that I use the waistband of their running shorts as a gait belt. Especially with women, will tell them I'm going to grab your shorts. So if you fall, I can ease you down. You don't want to grab a woman's pants with your hand without telling her why. You're very likely to get an elbow in the jaw. If the cramps are not improved, then we need to look for these other things. Rhabdomyolysis. If they have stiff, tight muscles, it could be rhabdo. And with sickle cell trait, it usually is not tense muscles. It is usually flaccid muscles. So that's a good consideration. If the cramps are not resolving, get some hands on this patient and feel to make sure that it is muscle cramp, muscle spasm that you're dealing with. And of course, we have to consider electrolyte problems like hyponatremia and consider giving IV fluids, but we also need to consider psychogenic causes. There are people who will come to the aid station grandstanding for their family and getting all kinds of attention when there's absolutely nothing wrong. So if we can identify a problem, go to the algorithm. If they don't have an identifiable problem and they continue to cramp, they need to go to hospital, because it could be ECAS, it could be rhabdo, it could be a compartment syndrome, and we can't deal with that. Rule number 9 in the Marine Corps is always carry a knife. I've been tempted to relieve an anterior compartment syndrome with my pocket knife, but have never had it. Chest pain. This is usually not going to be your bailiwick. You may be called upon, though, to go get me an aspirin tablet or a nitro tablet. And it's prudent to know that you don't want to give aspirin if they're allergic to it or if they have active bleeding. And you don't want to give nitroglycerin if they're hypotensive bradycardic, tachycardic, like greater than 120, or guys may already know this, if they've taken a 5' phosphodiesterase inhibitor like sildenafil, which is Viagra, within the past 24 to 48 hours. Even 1-nitro on top of that medicine can have such a profound effect on blood pressure that even with them in a recliner Trendelenburg state, they can have a stroke-like syndrome. The other things that medical people will entertain for chest pain is whether or not there's a pulmonary embolus, the likelihood of pneumonia. Person with, cold symptoms decides to run anyway, develops pneumonia in the course of the 4 hours they're out on course. It has happened. Myocarditis, pericarditis, we got to worry about that, especially if people have been given the COVID vaccines and they're young males, although that is a very rare response. And things that come from the gastrointestinal symptom like gastroesophageal reflux. Hyponatremia. This is a vexation. When we had point of care testing available, we were very much more comfortable with giving 3% saline to try and deal with this. For the most part, though, we are having to guess, and by golly, as to whether or not they could be hyponatremic. Another word for that is water intoxication. So if they are water intoxicated, we want to restrict water. We can give them hypertonic broth, which is horrible, but drink it down and have them eat salty snacks if they can take things PO. You have somebody that's coming in and they think that they're hyponatremic, they're going to end up in hospital more often than not. If they catch it early, you might be able to get them to go home with supervision. Probably not. Again, not likely your bailiwick. Hypoglycemia, you might see this. I don't know if you carry glucometers in your sideline bags or not, but you probably should, especially if you have diabetic athletes. They can become hypoglycemic. If a diabetic is less than 70 finger stick blood sugar, they're considered hypoglycemic, and we give them oral glucose if they can tolerate it. If they're non-diabetic, we want to make sure that it's even lower than that, less than 55. The 60, they're symptomatic of hypoglycemia, which is rare. But a person with hypoglycemia acts like they're drunk. They're slurring their speech, they're staggering, they are shaky, and they act like they're drunk. So the 4 or 5 S's of hypoglycemia. If you see it and you fix it, que bueno, adios to home. If you don't, there they go, back to a hospital. Respiratory things. You're probably going to be on this side of the algorithm. If somebody comes in and they're breathing like crazy and that their vital signs are good, OT stat is good, it could be that they're hyperventilating. So it may come to you to coach this patient out of hyperventilation. The old breathe into a bag trick is not what we do mostly these days. We do want to remove the person from the grandstand situation where they're being observed by others and reassure them that their oxygen saturation is fine and coach them in breathing control. So you say, breathe in with me, hold, breathe out, hold, breathe in, hold, breathe out, hold. And you get them then to stop blowing off CO2 and can usually get their symptoms to improve. If they do, we observe for a good 20 minutes so that they don't recrudesce, and then we send them out. If on the other hand, they're not improving, then we have to think about medical reasons for that, such as asthma. And I don't know if you keep albuterol inhalers in your bags or not, but 4 puffs through a spacer can be repeated a couple of times in order to make trial of albuterol get deep enough in their lungs to be helpful. Allergy anaphylaxis. Again, I don't know how many of you have seen a severe allergic reaction, such as the Stevens-Johnson syndrome or anaphylaxis. But if anybody has watched the Big Bang Theory, you may have seen Howard Wolowitz, that character, have a profound allergic reaction and have his face swell up considerably. You see it, you'll never forget it. The symptoms of anaphylaxis, of which if you have any two, you need to be hollering for medical. The cough, the stridor, the shortness of breath, choking, hypotensive syncope from falling out to the point where they fall out, weakness, dizziness, again, collapse, hives, swelling of the mouth and tongue, the lips turning blue or swelling the tongue, the uvula swelling. You may have to take a tongue blade and mash that tongue out of the way in order to maintain an airway. In any event, you get this stuff, you're calling for medical because it's serious business and they're going to the hospital. If on the other hand, they're not that bad, a Benadryl tablet capsule can be helpful. If you give them Benadryl, you have to warn them that this is a sedating thing. Do not drive. Do not drive yourself home after having taken Benadryl. You won't know how it's going to affect you until you run into somebody. Hydration guidance, we already talked about this. If they're able to drink, and we think that they've drunk too much, such that they're hyponatremic, get in touch with your senior medical officer to make sure that you know what you're dealing with. On the other hand, if they are not hyponatremic, and their eyes are sunken and they have poor skin turgor, get the Gatorade and see whether or not you can be helpful. Exercise-associated collapse. How are we doing on time? Oh my goodness, we're going to have to go quickly. Be careful. You could have tics and fleas. That is to say, it could be sickle trait and exercise-associated collapse with that, or it could be any of the other things that we've talked about that alter mental status and cause the person to get too weak to get up. One of the key features of exercise collapse related to sickle trait, and again, this can show up for the first time in these kinds of events. One of the things that is a hallmark or cardinal sign is that they are so weak or in so much pain that they can't get up. Again, this is somebody that's pulled into your aid station over the shoulder of a Marine. When that's a possibility, you got to get right away assessment for cardiovascular issues and get an AED on them straight away to make sure that it's not a heart-related thing. But if they have adequate pulse and their CNS function is not so good, we want to check that rectal temperature and make sure that we go through the other protocols, namely a hyperthermia protocol or the hyponatremia protocols, in order to make sure we get them treated. If, on the other hand, their sodium is normal and they don't get better over time, you have to think about the fact that that sickle cell crisis is not going to go away on its own. You need to get a large bore IV started and get them sent to hospital. One of the things we always start straight away is high flow oxygen, even if they have a pulse ox that shows they're well oxygenated. This is most importante, a very important thing to do. And remember to remind the EMS people in the ambulance to leave the oxygen on because it could be a sickle trait crisis. In considerations, I'm not going to spend a lot of time with that. We've had universal precautions for a long time. It's just made more poignant when we ended up with people dying from AIDS, or from not AIDS, from COVID. But if somebody comes into your station and they are wheezing or coughing, especially if they're coughing something up, don't hesitate to insist that they wear a mask. Don't hesitate to wear a mask yourself. Adaptive athletes. Wish we could spend more time on this, but let's just go through it as quickly as we can. All kinds of things can happen if you don't have legs or if you have a spinal cord injury, specifically if it is at or above the neck, the lower neck area, C6. C3, 4, 5, those nerves are responsible for keeping the diaphragm alive. So it's very unlikely that you'll see anybody with a dense 3, 4, 5 spinal cord lesion. Those are going to be on a respirator and lung. The folks who come in with a partial 5, 6 could have a disruption of their sympathetic tone. And what you'll see with that frequently is a blood pressure greater than 150 systolic. If they have that and a high pulse rate, you got to think about other things, but if it's low, you got to think that it could be because of their spinal cord injury, especially if they have things like headache that goes along with that increased pressure in their brain, as well as with that high systolic pressure. People coming in, with adaptive athletes are likely going to have medical personnel dealing with them, but the things that you need to know if you're on the sidelines is that the thing that can trigger them, they may not be able to feel. So, for example, if they have a fracture, they may not feel the pain of a fracture, but if you find it by palpating the bone and manipulating it, you need to splint it above and below the joint and perform also a skin check because, especially if they're in a wheelchair, if they have prompts to keep them up, they may have developed a pressure ulcer. Doesn't have to be ulcerated in order to be a pressure sore, to have enough pain that they can't feel that can still stimulate them to have an adverse reaction to it. So get that skin check done. When they come in a chair, loosen the straps that they have restraining them, get them out of their chair and sit them both upright in a chair, or leave them in their wheelchair without their restraining straps and sit them both upright, because it is a constriction of the abdomen that can do all kinds of things, namely kinking off their bladder catheter. If they have a full bladder, they may not be able to feel it, but there could be a physiologic response to the full bladder. If they have a catheter, drain it. Even though they said they drained it before the race, drain it anyway. That gives you a chance to look at the urine and see whether or not they have that brick red urine that goes along with the myositis of either the myositis of rhabdomyolysis or the myositis of the malignant hyperthermia situation. For the most part, the adaptive athlete is going to have issues that we can deal with, and hopefully we'll get them where we can say adios. If we don't, then we'll send them on. Other considerations, we're not going to go into the proper push rim technique or hand cycle techniques, but related injuries can show up with either push rim wheelchair athletes or hand cycle athletes. The wrist, especially if the split cord is exquisitely tender, could be fractured in that process. There's always, of course, the tendonitis, the ulnar and medial nerve compression issues that show up when you tap the volar surface of the wrist to find that there's a compression-related tingling and problems there. The other thing that happens with adaptive athletes, especially wheelchairs, not so much with the hand cycle, but the wheelchairs can wreck. They can roll over. I had a guy show up at Aid Station Delta who was the victim of a rollover. The adaptive athlete himself ended up in a aid station at the site of the But this guy was an innocent bystander. He was wiped out by the rolling wheelchair, and it tore his little running short to shreds to the point where it was hanging by a couple of threads, and the only thing that was covering him was that little underpants that's under the running shorts. Well, he was parading around very proud of his exposure, very proud of his equipment. He also had an abrasion that went from his thigh, skipped his knee, and picked up his gastroc and all the way down to emulsion of skin on the lateral malleolus of his ankle because of that road rash. But he ran on, had a sock full of blood, and we got him cleaned up with as best we could, and insisted that he go to the emergency room to get better wound cleaning and treatment. So they can wreck. I'll also point out that I found where is any athlete suspected of anatomic dysreflexia. And I think we talked a little bit about that, having signs or symptoms above and below the spinal cord injury that are not consistent, having the cold clammy skin, and that high blood pressure thing. It's not a suspected athlete, but an athlete suspected of. Mental health issues, again, you're not likely to have to deal with that, but what we see in endurance events is that some will break down from the sheer elation of having finished the event. And some will break down for the elation of having met their PR. And some will break down because of their failure to meet their PR, the feeling of losing. Sports psychologists are helpful, you think, mainly in terms of dealing with training pressure, social pressure, performance pressure, dealing with the sequelae of injury, but they can also be helpful at the end of an endurance event relative to psychological issues. I'm not going to go into this. The stuff that we see that is not in the algorithms, blisters, mostly on the feet, but can be between the toes. If it is bulging and full of fluid, you're afraid it's going to pop on its own, probably prudent to take a 23 gauge needle and puncture the edge of the bubble and bleed it out. Get it is to say, get rid of the fluid in it so that it doesn't rupture, doesn't shred. That way that skin, that overlying skin will dry out, and when the underlying skin regenerates, the overlying skin will start to lift and the patient can pull it off. Applying a fenestrated dressing is something that's really helpful. You want to make sure that the hole is as big as the lesion, and that the gauze around the prevents pressure on the lesion itself, on the blister itself, and that can be a pretty creative effort when you have blisters between the toes. Adaptive athletes can also get blisters on their hands even if they wear sports gloves, and need to deal with them. Sprain strain, I'm sure you guys deal with that. I imagine you've taped up your share of ankles before, during, and after athletic events. Knee-related issues can happen, and to have a double upright anti-rotational knee brace available can be really helpful to get somebody out of your aid station and home or to the emergency room without having to go via ambulance to deal with their knee. We also have knee immobilizers if we have an unstable knee. Again, there's no algorithm for that. You just have to be know enough to deal with it. Trip and fall. Oh, you can get all kinds of stuff. You can get sprains, you can get abrasions, you can get avulsions. I had one guy who fell on the outside of his hand and avulsed the skin from the back of his hand. But certainly bad road rash, but also lacerations. I had a Marine in a trail race that's in Brentwood Forest. It's called the 1775 race, 17.75 kilometers through the woods. A root jumped up and tripped this Marine, went down on a rock right below the knee, and lacerated the skin all the way down to the infrapatellar tendon. I immediately, I'm seeing this wound, but by the way, she walked into the aid station. I immediately looked up and hollered for a corpsman to get started for transpo. We have to transport this patient. And she said, no, sir, I'm not going. I am finishing this race. I walked in here and I'll walk the rest of the race if I have to. Is there nothing you can do for me? And under those circumstances, knowing that, you know, her colonies were on the line, I had to decide what to do. And what we did was we took a 50cc syringe and some normal saline, and we squirted as much of that manure out of her wound as we could. And I went ahead and put some triple antibiotic in the wound, which you're not supposed to do. Of course, it's topical. I put it in the wound thinking that a deep space infection would be worse for her than the inhibition of wound healing that comes from the topical antibiotic in the wound. I put it together with several pieces of athletic tape that were about 8 inches long, in the center of which I had folded over bits to make them into steri strips. So I put her knee back together. I padded it up with Telfa and 4x4s, wrapped it up with a ace wrap. And because we were on a figure 8 portion of the track where we're here, she had to run around and come back by us. I felt okay to let her go as long as she could handle it. And she, sure enough, came by smiling and waving. And I admonished her again, as soon as you get finished, you head to the emergency room, young lady, playing my best grandpa role. The evulsions and fractures we talked about, some of the things that happen in endurance events, especially in the wintertime, is that at the water stations, people will slosh water on the ground, and it sure enough freezes up and makes that into an ice skating room, and zip, zoom, down they go. Colles fractures, forearm fractures, point fractures in the wrist, those kinds of things show up. Here's the supply list, and you'll notice there is no tape. Here's the drug list. I don't know that you'll need to know much about that. What I've hoped to do, and I know we've run over these algorithms, I remind you that they're free for you to use. If you need to pass them on to other people, you need to get permission. However, be aware that this document is fluid. We change it nearly every year. This is the September 24 edition. It is under constant revision as we learn more. So if it is next year before you're using it, by all means call Dan or send them an email and get the latest version as well as permission to use it. There's a wide variety of adaptive and special athletes that will come to your attention. They're going to have their share of emotional, mental difficulties too. And whether you're courtside or on the sidelines, your role is critical for the best possible outcomes. I thank you for your attention, and I stand ready to answer any of your questions.
All right, great talk, and we'll give people a minute to put in questions if they have them. But that was fantastic. Certainly a breadth of information there.
We're 80 minutes long, so I tried to cut back to the things that I thought that ATs would not necessarily have to deal with, but I don't know your specific circumstances. So again, I'm open to any questions.
Yeah, I feel bad for the guy you were saying, the guy who got decked with a good left hook there in the midst of trying to put in an IV. Oh my gosh.
Came that left and caught him right under the jaw, put him right back on his back and with a collapsed jaw, knocked him out. So we had to have him sign in as a patient in our aid station. The other thing I've had to deal with is, we have to be there at 04 in order to get transported to our aid station via whatever means they have. And then we have to set it up. One year I had the chief supply officer was trying to get that canopy set up, and the slide slipped and took a big chunk out of his finger. Gratefully, it was lying off to the side, but it was down to the bone. And again, he said, "I'm not leaving. This is my duty station. Put me back together." So I had to mobilize that flap, put it back over, get it all cleaned out, tape it all up, and he lapsed it through the whole thing. His name is Careerathon, and I touched base with him about a couple weeks later. He said he went to the doctor, and the doctor said, "Man, you're a tough individual to put up with that," but they saved that fingertip.
Awesome. Awesome. Well, very cool. Thank you so much, Dr. Hostetler. It's always a pleasure to hear from you. And I know, certainly this comes from requests from attendees to have a talk about this, as well as you and I were chatting while you were in the preparations of putting together your marathon site. So I'm really glad that we were able to get this presentation together.
And one of the things that this now is that Commander Madsen would be available to come and do a session for you specifically on adaptive athletes, because he has done so much work in that regard.
That would be great. We have received quite a few, for our attendees who are here right now that are still jumping on, these are the things where, sometimes you guys have specific requests. We do our best to find speakers, and sometimes we can find speakers, sometimes we're unfortunately unable to. So, but that would be great. We have definitely received requests to have an adaptive speaker. Sweet. And then we just got no questions, just a quick comment from William saying thank you and appreciate a very comprehensive presentation. Absolutely. All right. Well, have a great night, everybody.